Should I broadcast?
All righty. Hello, everybody. Just sitting tight here, waiting for everybody to join. I'm going to wait a few minutes and give everyone a chance to log in. We will start momentarily. It's one more minute for people to have a chance to log on. Welcome, everyone. I am Adam Lush, the Regional Resource Director for Caron Treatment Centers serving the Greater Philadelphia region. Thank you for joining us for the 18th installment in our webinar series, A View from the Mountain, Caron's Perspective on Addiction Treatment in the Wake of COVID-19. And today's topic, Trauma, Addiction, and Post-Traumatic Growth. Today's presentation is eligible for 1 hour of social work continuing education credit. We would like to thank our educational sponsor, Jumana Grassi, for assisting in obtaining these credits. Please keep your Zoom session open at the end of the presentation to access the post-event evaluation to obtain your 1 hour credit. In order to receive your credit, you must stay on for the duration of the webinar. A certificate will be emailed to you from Jumana within the next 2 weeks. As a reminder, we will be conducting this session in webinar format. All participant microphones will be muted. During the presentation, please utilize the Q&A feature to ask any questions you may have. Depending on the volume of questions, if we can't get to your question before the end of the hour, we will have someone from our team follow up with you directly. This week, we are welcoming a guest speaker, Dr. Scott Giacomucci, who is the director, founder of the Phoenix Center for Experiential Trauma Therapy in Media, Pennsylvania. He is a doctor and a board-certified diplomat of clinical social work. Dr. Giacomucci is also a fellow of the American Academy of Experts in Traumatic Stress and a certified EMDR consultant. He serves on the Executive Council of the American Society of Group Psychotherapy and Psychodrama, the Advisory Board of the International Society of Experiential Professionals, and Trauma and Disaster Task Force of the International Association of Group Psychotherapy. Dr. Giacomucci is the recipient of various national and international awards, most recently as the first recipient of NASW's Emerging Leader Award and the 2019 Group Work Practice Award from ACA's Association of Specialists in Group Work. He regularly presents at regional, national, and international events and is an adjunct professor at Bryn Mawr's College of Graduate School of Social Work, teaching a course on trauma-focused psychodrama. He has published various peer-review articles, writes a psychodrama column for APA's Division 49 newsletter, and co-edited the autobiography of psychodrama's founder, Jacob Moreno. Scott also serves as a co-editor of the first international psychodrama book series recently announced by Springer, titled Psychodrama in Counseling, Coaching, and Education. He is currently working on a forthcoming book integrating sociometry and psychodrama within the field of social work, covering practice with individuals, groups, and communities. Please welcome Dr. Scott Giacomucci.
Thank you, Adam. Thanks for the introduction. And I want to give a special thank you to Caron for the invitation to present on this webinar. Good morning, everybody, and thank you for joining us. Just to give you a little more background about myself and my way of presenting, as you heard, I'm a psychodramatist and an experiential therapy trainer. So I try to make all of my presentations experiential. It'll be a little harder in this webinar format, but I've done my best to keep everybody engaged. So it'll be a little more than just presenting slides. we'll have some experiential processes, one at the beginning and one at the end. So our learning objectives for today include identifying one connection between addiction and trauma, explaining the difference between trauma-informed and trauma-focused, and describing post-traumatic growth. So first we're going to start with what I call spectrograms. Usually when we do a spectrogram, it's a group as a whole assessment that we use in person, although we've had to modify them for online formats. The way we're going to do it here on the webinar is through a poll. So we're going to use the Zoom poll feature. The question we're going to ask is, how connected do you see addiction and trauma to be? So I'll ask you to go ahead and answer that question on the poll. And while the answers come in, I'm just going to explain what this would look like if we were on a Zoom meeting or if we were in person. So a spectrogram is basically looking at the group as a whole on a spectrum. If we were in person, I would designate one side of the room to represent a 0 out of 10 or a 10 out of, or a 1 out of 10, and the opposite side of the room to represent a 10 out of 10. So we'd have a continuum within the physical space of the room. And I would offer a prompt such as the one that we're working with today, how connected do you see addiction and trauma to be? And I would ask everyone to physically place themselves on the spectrum based on their answer to the prompt. So we would have a visual sense of where everybody's at in terms of their understanding. You can use this in Zoom meetings or Skype meetings or Teams meetings. As long as everybody can see themselves, we can use the height of the camera view as the spectrum. So I would ask people to put their hands towards the bottom to represent a 0 out of 10, or their hand at the top to represent a 10 out of 10, or any space in between. And it allows us to see each other and see where we fit in within the group. Of course, it's much more dynamic process in person as it forces people to talk to each other and you get to move around a bit, but also doable online. Just looking at the poll results, it looks like most of the group falls in between 70 to 100% in terms of how connected you see addiction and trauma to be. So that'll make my presentation very easy because it seems that you all already have a good foundation for this content. Now, if the answers were different, if most of the group fell between, say, 10% and 30% on this spectrogram, I might give a very different presentation based on my assessment of the group here in the beginning. So a spectrogram is unique in that it really allows you to assess the group and then meet the group where they're at. The spectrogram tool comes from the field of sociometry, which is part of the triadic system of psychodrama and group psychotherapy. And sociometry it's basically just a fancy word that means group dynamics, but it's looking at the evolution of groups and the position of individuals within groups. And the founder of psychodrama, Jacob Moreno, he argued that because we always start psychotherapy with assessment, that we also need to start group work or community work with assessment. And so he created this field of sociometry, which allows us to assess groups, not individuals within a group, but to assess the entire group at the same time, as you can see how the spectrogram does that. So I want to thank you for participating in the spectrogram here. So to start things off here, I think it's important that we address the difference between trauma-informed and trauma-focused. I often hear these used interchangeably. I hear people on the chat saying they can't hear, so I'm going to try to speak a bit louder. If you need to, you could go ahead and turn up your sound as well. So one of my pet peeves in the field is how people use trauma-informed and trauma-focused interchangeably. They're not the same thing. It feels like everybody says they're trauma informed nowadays, and I think it's important that we precisely look at what trauma informed is and how it's different from trauma focused. So when we talk about trauma informed, we're talking about the process of providing services. We're talking about systems, we're talking about a philosophy of from which we work. These are the 6 principles of trauma-informed care, which include safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and addressing cultural, historical, and gender issues. So when we're working from a trauma-informed perspective, it's important that we're considering these 6 principles and how every aspect of our treatment approach embodies these, from our policies to the physical space that we're conducting treatment in, our intake policies and procedures, the actual therapy that we're providing, all the way down to frontline staff, the way that the kitchen staff interacts with our clients, or the way that support staff or drivers interact with clients. Now, this is different than trauma-focused. When we talk about trauma-focused, we're talking about specifically treating trauma-related issues and post-traumatic stress disorder. The trauma-focused more so describes the content of the therapy rather than just the process. And I would even argue that there's many providers that I've experienced who are trauma-focused. They're focusing on treating trauma, but they're not doing it in a trauma-informed way. I think we really risk re-traumatizing our clients when we're working with trauma without proper training and without consideration to these 6 principles: safety, trustworthiness, peer support, collaboration and mutuality, empowering the clients, giving them choice and voice, and addressing how cultural issues, race, gender, oppression, societal issues, how these impact their clients and how we might be unconsciously reenacting them within our agencies. So when I think about addiction and trauma, I think about them as having a cyclical relationship. I'm seeing on the chat difficulty hearing, so I'm going to try to adjust some of my settings here. Sorry about the technology issues. Is this any better? Can you all hear a bit better? Yes, okay, perfect. Thank you. Thank you for letting me know that the sound wasn't perfect. So just picking up here, looking at trauma and addiction as a cyclical relationship. From what I've seen, that they really fuel each other. It's hard to look at them or isolate them, especially when working in the addiction field. So often there's trauma that underlies the onset of addiction or alcoholism or substance use. And then the lifestyles associated with being addicted or dependent on a substance or alcohol so often create more trauma, more loss. And so they really are fueling each other. Some trauma experts have gone as far as saying or suggesting that all addiction is a result of childhood trauma. I'm not sure that I would use a black and white statement like that. From what I've seen, most of the addiction clients I've worked with have a history of trauma. I've also worked at Miramont Treatment Center for 10 years now, and I oversee their trauma services there. So I've spent a lot of time working with addiction. Interesting kind of clinical example related to my work at Miramont. When they originally started the relapse prevention program using Gorski's framework, what we noticed was all the clients that were ending up in this specialized program for relapse prevention because they had histories of being in and out of treatment and in and out of recovery. When we looked at a more thorough assessment of their histories, they all had unresolved trauma, unresolved grief and loss that wasn't being addressed. And from this realization, we created our trauma programming. And I think in the past decade or two, a lot of treatment programs have been doing the same thing, that we're becoming much more conscious as a field in terms of the underlying issues of trauma and loss, adversity, and how they intersect with addiction. So one thing I heard in graduate school that always stuck with me was that all addiction treatment is trauma treatment. So just to cover some statistics here, in case you don't believe me, here's some of the research. In research, they found that 70% of adolescents in substance use disorder treatment report a history of trauma. 80% of women in treatment report a history of physical or sexual assault. And now these are self-reported numbers, so the actual numbers are almost definitely a bit higher, especially considering the way that trauma impacts memory and how one of the core symptoms of trauma is around minimizing and denying it. So I would expect these numbers, 70 and 80%, to be a bit lower than what the actual statistics would be. I would guess that they're closer to 90%. In research, they also found that those who have a substance use disorder diagnosis are 7 to 12 times more likely to also qualify for a PTSD diagnosis, a post-traumatic stress disorder. So we talk a lot about co-occurring disorders in the field. However, I think sometimes we forget to include PTSD as a co-occurring disorder. It's actually the most common co-occurring disorder with alcohol use disorder. And there's some insights from neurobiology that I'll offer in a moment that might explain some of this. So PTSD symptoms, of course, are largely related to the nervous system. Alcohol is a depressant for the nervous system, as are benzos. And so for someone who's experiencing PTSD symptoms, especially hyperarousal, intrusive images, nightmares, anxiety, a loss of safety, their nervous system is hyperactive. And so it would make sense that they might gravitate towards using alcohol or benzos to self-medicate and calm the nervous system down. I'm actually pretty convinced that if the founders of AA, if they had written the big book a couple decades later, once PTSD was recognized as a diagnosis and trauma was a little more within the forefront of our consciousness and society, I'm pretty convinced that they would have addressed and talked a lot more about trauma and PTSD. Though the AA was founded several decades before PTSD was recognized as a diagnosis. So most traumatic experiences are relational in nature, relational trauma, which means they take place within the context of relationships. So this really impacts our ability to use relationships to self-soothe. One of the important findings from the field of interpersonal neurobiology is that all mammals, including humans, we use relationships to calm ourselves down, to self-soothe, to manage our emotions, especially fear. It really helps to be in relationship with another calm nervous system in order to calm our own nervous system down. So if the nature of our trauma is relational, it really impacts our ability to socially engage and to self-soothe because of that. Now, when trauma takes place in childhood, it can really impact the development of the brain. What we know from research is that attachment in early childhood is essential for healthy brain development. And that when we don't have attuned caregivers, and we don't have all of our needs met in a good enough way, it doesn't have to be perfect, just a good enough way, it can really impact the development of our brain and the development of a sense of self, which impacts our functioning later in life. A really fascinating finding in the neuroscience research was that when they took a scan of someone's brain who was experiencing physical pain and another scan of someone's brain who was experiencing social pain, or the pain related to rejection, loss, the brain scans looked identical. They couldn't tell whose brain was whose, which suggests that our brain uses the same mechanisms, the same processes when we experience physical or social pain, that they're really overlapped and interconnected internally. So from what I've seen, this makes a lot of sense in terms of opiate use. One of my favorite addiction speakers, Gabor Mate, he always suggests that rather than asking clients why the addiction, we should be asking them why the pain. What's going on that you're in so much pain that you need to self-medicate, that you need to numb the pain? And so anyone that's used opiates knows that they work really well at numbing pain, whether it's physical or emotional. I think there's some connection there. I wouldn't be surprised if there was some overlap between opiate use with attachment trauma, relational trauma, and specifically loss. And so when trauma impacts our ability to self-regulate, it only makes sense that somebody might look for outside things that can provide regulation. Things like drugs or alcohol, sex or gambling, food or workaholism. Really, there's a whole range of behaviors that can be potentially addictive when not used in moderation. So, as you learned in my introduction, most of my background is with the experiential therapies, which are a little different than talk therapies in that we're going beyond just talking about an issue. Psychodrama is often categorized as part of the creative arts therapies. Many people don't realize that Jacob Moreno, the founder of psychodrama, also coined the term group psychotherapy. And he did that in 1932, right here in Philadelphia at an APA conference. Psychodrama's birthday is considered to be 1921, April Fool's Day. So in less than a year here, it'll be celebrating its 100th birthday. So it's the oldest group therapy and the first body-oriented therapy. Now, a number of people are starting to claim that experiential therapies are the treatment of choice when working with trauma because of all this new neuroscience research that's emerging. What we know based on the neuroscience of trauma is that trauma impacts parts of the brain below cognition, below talking. It impacts the limbic system. It impacts aspects of the self beyond consciousness. And it impacts the body. And so if trauma and addiction, for that matter, both impact us below cognition, below words, it makes sense that our interventions also need to go beyond talking, that we need to include the body in our interventions. And there's a number of different ways to do that. There's a whole range of experiential therapies and creative arts therapies, music and art and drawing, poetry, movement, dance therapy. Yoga is really important in trauma healing. In some research, they even found that yoga was more effective at reducing PTSD symptoms than any medication that's ever been researched about PTSD. And it makes sense if you think about the process and the experience of participating in yoga. It really challenges us to find safety in our body and to, in really small amounts, tolerate distress. to hold a physical pose, knowing that it's going to end shortly, but just to hold it a little bit longer and to tolerate it a little bit more. My sense of yoga is that it really trains us to widen our window of tolerance. Therefore, it can be really, really powerful and really important for anyone in recovery from addiction and or from trauma. So here's a quote from Bessel van der Kolk. I'm guessing most viewers are familiar with Bessel. From what I can see, Bessel's probably the foremost expert in the field right now when it comes to trauma. His book, The Body Keeps the Score from 2015 is, I would argue, the best overall comprehensive introduction to trauma. I highly recommend it if you haven't read it already. So Bessel says that prone to action and deficient in words, trauma survivors can often express their internal states more articulately in physical movements or in pictures than through words. Utilizing drawings and psychodrama may help them develop a language that's essential for effective communication and for the symbolic transformation that can occur in psychotherapy. So in some other trauma research, what they found was when we asked someone to remember a traumatic memory and take a scan of the brain, most parts of the left hemisphere of the brain are offline, including the Broca's area, which is the speech and language center of the brain. And the right hemisphere of the brain is much more active. The left hemisphere, generally speaking, this is very generally speaking, left hemisphere deals more so with functions related to cognitive processing, speech and language, meaning making, integration, abstract thinking, and future planning. Whereas the right hemisphere, generally speaking, is more related to emotions, to images or pictures, sensations. And again, this is very generally speaking, it's not one side or the other. But this research really challenges us working with trauma to consider integrating adjuncts or alternatives to traditional talk therapy when we're working with trauma. Of course, talking and making sense of and cognitive processing is important when we're working with trauma, but sometimes we need to start with other approaches. There is a growing research base around the humanistic experiential psychotherapies, abbreviated as HEPs, and the body and movement oriented interventions, abbreviated as BMOIs, that demonstrate that they're at least as effective as prolonged exposure or cognitive behavioral therapy when working with trauma-related issues, and that they often have lower dropout rates than approaches such as prolonged exposure. And there's a ton of meta-analyses and publications about this. I just published a study from my inpatient work at Miramont about using trauma-focused psychodrama with clients in inpatient. And we had some promising results after only four groups, participating in 4 groups over the course of 2 weeks within the inpatient setting. On average, our clients were experiencing a 25% reduction of PTSD symptoms, which is 2.5 times the clinically meaningful threshold. Now, the research wasn't perfect, and there's some limitations to the research design, but there's definitely some promising research out there related to the experiential therapies, the body movement oriented therapies, and the creative arts therapies. Now, most people have probably heard of the ACE study. ACE stands for Adverse Childhood Experiences. This study was done a couple decades ago, and it was a simple yes or no questionnaire with 10 items. And there, like any research, there's some limitations to the research. Originally, they did this study with 17,000 participants, which is a pretty large sample size. And since then, they've modified it to be more culturally appropriate, and they've redone the study in a number of different communities and cities. Across the board, what they've found was that adverse childhood experiences were significantly more prevalent in Black and Latinx communities, and that they were actually lowest in Asian communities, which is pretty interesting. More white and Caucasian communities fell in between Asian and Black and Latinx communities in terms of the likelihood that participants reported at least one childhood adversity. What they found was that across the board, ACE scores were correlated with a variety of medical and mental health issues. And this is an image that shows the original 10 questions that they were asking about, which included abuse, neglect, and family or household dysfunction. So when they correlated the scores with the ACE study, what they found was that somebody who reported 4 ACEs, 4 different types of adverse childhood experiences, they were 500% more likely to present with alcoholism in adulthood. Pretty strong correlation there. Again, 4 ACEs, they were 13 times or 1,300% more likely to use IV drugs in adulthood. And again, the higher the ACE score, the higher the chances of mental health, addiction, or medical issues in adulthood. So somebody with 6 or more ACEs was 4,600% more likely to use IV drugs. This is specifically for males. That's 46 times more likely. Really strong correlation. 20-year less life expectancy for somebody with 6 or more ACEs, which is incredibly sad. The rate of prescription drugs increased significantly for every ACE score. And what they also found was that childhood adversity was also strongly related to medical issues that we often don't think of as being related to trauma. Things like lung diseases, heart diseases, diabetes. These were all connected to childhood adversity. Now, one of my classmates in my doctorate program did some really interesting research looking at the outliers in the ACE study, those who scored really high in terms of the number of adverse childhood experiences, but did not report or did not present with negative health outcomes in adulthood. And they were looking at, what makes these people different? What was their experience that provided increased resilience or preventive factors? And some of what they had found was that one important factor, preventive factor, was just having at least one nurturing adult relationship. That the presence of one attuned adult really was a preventative factor for mental health and medical issues later in adulthood. And that one present and attuned adult doesn't have to be a therapist, although oftentimes it is. It could be a parent, an uncle, a neighbor, a coach. It could be you, it could be me. It could really be anybody. A number of trauma experts are suggesting that the likelihood of someone developing PTSD after a traumatic event has less to do with the event itself and more so to do with what happens directly after the event. Was there somebody who was present and attuned with the trauma survivor immediately after the event? Did they experience validation, compassion, connection, regulation? That what happens after the event might be more predictive of PTSD than the actual event itself. And in this research about the outliers in the ACE study, another interesting piece they found was that these outliers were often engaged in the creative arts as children. they were working in the theater, they were engaged in drawing or adventure in outdoors, poetry or music, played instruments, that there seemed to be something related to creative expression that helped them process, make sense of, and bounce back from adversity. So when we talk about trauma, I think it's also essential that we talk about post-traumatic growth, growing from trauma. Some people have heard about post-traumatic growth. I think it's becoming more and more popular nowadays. The phenomenon of post-traumatic growth has been around probably since the beginning of our species, the beginning of civilization and humanity. You can find examples of post-traumatic growth in any legend or myth or religious or spiritual text. It's simply the phenomenon of growing as a direct result of trauma or adversity. That because of difficulty, we actually grow. We can grow from it. In the research, they found there's 5 unique domains of post-traumatic growth, 5 different categories from which the growth, ways that it manifests. And these 5 categories are a sense of personal strength, that after experiencing trauma or difficulty, I might have a better, might have a stronger sense of self. I might feel like, wow, if I experienced that and got through that, I could get through just about anything else. Or maybe if I survived that trauma or difficulty, I'm realizing I have a lot more courage or resilience than I thought I did before that. Second category is about interpersonal relationships. That after experiencing trauma, perhaps I place more value in my relationships. I realize how important relationships are. I realize that the good people in my life are really more important to me than they were prior to experiencing trauma or loss. I place more value in my relationships or community. I think we see this quite a bit in addiction recovery. And I've even started to think about and frame addiction recovery as post-traumatic growth, as growing from the trauma of being addicted or dependent on a substance. The third category is about spiritual or religious connection. Originally, the research focused on religious connection. Since then, they've expanded it to spiritual and sometimes even existential connection. That after experiencing trauma, which is so often at the hands of other human beings, many people look to spiritual or religious traditions to make sense of the trauma they experienced. And because of that, develop a stronger sense of connection to a higher power, to God, to archetypes, to their spirituality or religious tradition, whatever that may be. Fourth category of post-traumatic growth is about new opportunities or possibilities in life. That after experiencing trauma, maybe I realized that there's other opportunities in life. Maybe it turned my world upside down and I'm looking at life in a different way. Maybe it opened doors that I didn't think would have been possible previously. Maybe I realized I can use my experience to help somebody else now. This is a great example connected to addiction recovery. That after experiencing addiction, I can use my experience, strength, and hope to help somebody else who's struggling with addiction. And the fifth category of post-traumatic growth is about a greater appreciation for life. So often after experiencing trauma or difficulty, again, it turns our world upside down. And it helps us, it can challenge us to appreciate life in a new way, to have a greater sense of enjoyment or joy related to even the small things in life, or simply to value our life more after it was threatened. You hear a lot of talk about a greater appreciation for life in addiction recovery. And people talk about how I really needed to experience the pain in order to experience the joy at this depth, at this level. So these are the 5 domains of post-traumatic growth. I think it's really hopeful statistics here. When we look at the likelihood of someone developing PTSD after experiencing a traumatic event, and these numbers are for adults specifically, 1 out of 4 adults who experience trauma will develop PTSD symptoms, whereas 2 out of 3 adults that experience trauma report some level of post-traumatic growth. That means you're 2.5 times more likely to experience post-traumatic growth after trauma than you are to experience PTSD. Again, this is really, really important to convey to our clients that trauma can create really positive changes in our life, in addition to really being damaging and painful and difficult and harmful. It's not one or the other either. So PTSD and post-traumatic growth elements can exist together. And it's pretty common that someone after trauma experiences aspects of both. They might experience some PTSD symptoms while also demonstrating post-traumatic growth at the same time. If you're interested in learning more about this, there's a lot of writing and research on it. There's a research-validated assessment tool called the Post-Traumatic Growth Inventory that you can use with clients. It can be really useful as an assessment tool at the beginning of working together with clients, or even as a evaluation tool in the middle or towards the end of working with clients to assess any changes in post-traumatic growth. Just to go back for a second, in my work with clients, when I present the idea and the phenomenon of post-traumatic growth, usually across the board, they talk about it really, really helping to instill hope for them. I had a client recently who said that he's been in and out of trauma treatment, and the focus was always on the negative. It was on the trauma, it was on the symptoms, it was on the pain and the flashbacks and retelling the story. And that being in my Phoenix groups, where we talked about post-traumatic growth, really gave him a template for moving forward, a roadmap for what growing after trauma could look like. That there was a piece related to recovery beyond just telling the story of trauma or processing the negative feelings or impact. That these domains of post-traumatic growth provided a future template, so to speak, for what to strive for, what to look for, and what to cultivate, the rewards of trauma treatment per se. So I think they're essential that we're talking about post-traumatic growth when we're working with trauma. The namesake of my company, the Phoenix Center, is about the legendary figure, the Phoenix. And of course, the Phoenix, which in some form is a cross-cultural symbol. You'll find legends and myths related to the Phoenix on just about every continent. The Phoenix is a symbol of post-traumatic growth, of being reborn from the ashes. So all the work that I do is not just, all the trauma work that I do is not just focusing on the trauma, but also focusing on the growth after trauma. Now, this is a kind of subset of the research literature on post-traumatic growth that I stumbled upon while writing a chapter for the book that Adam had mentioned. And I don't think I've ever heard anyone really present on this. It's not new. There's publications on it going back 10 years or so, although I often think about my research professor at Penn in my doctorate program, She says that it takes about 17 years for research to translate into clinical practice, which I think is really unfortunate. We really need to shorten that time gap because there's so much research out there that could be really helpful in informing the way that we practice. So maybe it'll take a few more years for vicarious post-traumatic growth to really become popular in the field. So what vicarious post-traumatic growth is post-traumatic growth experienced by the professional as a direct result of vicarious trauma professional experiences when working with trauma survivors. So what that means is that you and I, or our colleagues, employees, or staff, when working with trauma survivors, that there's also a potential for the professional to experience growth as a direct result of the work. And I think any of us, if we were to reflect on our clinical work with addiction or trauma, we can find some examples of ways that we've grown as a direct result of doing this work. In the research, they found that vicarious post-traumatic growth is experienced by all types of professionals, not just psychotherapists, but lawyers, caseworkers, social workers. I think there was even a study on interpreters. Across the board, professionals who work with trauma experience vicarious post-traumatic growth. One piece of literature in the research that was interesting to me was that they found that humanistic and transpersonal therapists report more vicarious post-traumatic growth than therapists who work from a cognitive behavioral perspective, which was pretty interesting. They also found that vicarious post-traumatic growth increases significantly when the professional is engaged in a self-care process, when the professional is engaged in supervision, when the professional has peer support with colleagues in or out of the workplace, and or when the professional is engaged in their own personal therapy. So these are all ways that we can cultivate vicarious post-traumatic growth for ourselves by engaging in self-care, supervision, peer support, and personal therapy. Now, many of us also work with first responders, or maybe we provide therapy or services for professional populations. I know Caron has signature programs that work specifically with emergency responders or healthcare professionals. This is also an important concept when we're working with these populations that we can incorporate into our framework, that we might be able to help our clients who are professionals to explore both ways they've been vicariously traumatized by their work and ways that they've experienced vicarious post-traumatic growth. Again, we're not just focusing on the trauma or the negative, but we're also looking at the positive. If you examine any clinical map related to trauma work, you'll just about any clinical map is structured in a 3-phase process when working with trauma. That we're always starting with safety, containment, strengths, education, skills building in the first stage, then moving into the trauma content and processing trauma, difficult emotions related to trauma. Often this is the point where a client might retell their trauma story, though it's also important to note that there's ways to heal from trauma without telling all the details of the trauma story. Sometimes in the second phase, we're working with defenses related to the trauma or secondary gains. And then the third phase of most clinical maps related to trauma is about meaning making. It's about integration. It's about transformation and post-traumatic growth. Having processed some of the traumatic memories and feelings, how do we integrate this new learning, this new experience into our lives going forward? Outside of treatment, into the future? How do we change our sense of self to be growth-oriented? What does post-traumatic growth look like in action? So just conscious of the time here, we have 10 minutes. So I want to do a quick psychodrama vignette with everybody, and you can choose to participate in this or not. Thinking back to these 5 domains of post-traumatic growth, these are the same 5 domains of vicarious post-traumatic growth. I'm going to ask you just to take a minute to envision a version of yourself as a professional, embodying all of these 5 domains of post-traumatic growth. So what does it look like if I were to fully embody a stronger sense of personal strength, stronger sense of interpersonal relationships, a stronger sense of spiritual or religious or existential meaning or connection, a new sense of opportunities or possibility, and a greater appreciation for life. And just to take a moment to create that image of yourself fully embodying these 5 domains of post-traumatic growth and vicarious post-traumatic growth. What would it actually look like in the different areas of my life if I were to embody post-traumatic growth? And see if you can have a visual of yourself in post-traumatic growth. Maybe it's in the future, maybe it's an ideal version of yourself, having grown from vicarious trauma, maybe having grown from personal trauma. And really take a moment just to tap into that vision for yourself. And I'm going to ask you just to imagine for a moment that version of yourself, in post-traumatic growth, is standing directly behind you, maybe with a hand on your shoulder. Maybe it's a future version of yourself. Again, it could be an ideal version of yourself. Just to feel the presence of this version of yourself. And now what I'm going to ask you to do, if you're willing to participate, is to role reverse with this version of yourself. To stand up and to switch roles and stand behind your chair. And for a moment to become this different version of yourself in post-traumatic growth. And to see yourself sitting in the chair in front of you. And from this place, this other version of yourself in post-traumatic growth, I'm going to ask you just to articulate one message. What's the most important message that you'd like to say to yourself about growth, about growing from trauma, or about helping clients grow from trauma, or about growing from your own vicarious trauma? And you might speak that message out loud. When we speak things out loud, it really helps to make them real. You might put it in the chat box, or you might say it just in your mind for yourself. Find what's the most important message to say to myself about vicarious post-traumatic growth. So, for example, I might say to myself in the chair in front of me, keep consistent with your self-care processes and don't forget to look for the goodness and the growth that you experience because of your work. All the meaning and purpose that it gives to you. And once you've made that statement, I'll invite you just to role reverse again and come back to yourself. Go ahead and put that message in the chat box if you would like to. We have a number of messages coming through in the chat box. Growth is fluid. Keep expecting good things. You're not done yet. Doesn't have to be perfect. Let go and let God. Keep continuing on this journey. You've come a long way. Keep going. Keep on driving in the spirit of adversity. Live life to the fullest. You are strong. Keep positive. Do what's hard to do. You are worthy. So I'll invite you to take in all these positive messages of post-traumatic growth for yourself. Be kind to yourself. If you found this exercise meaningful, you might even choose an object in your office that can symbolize this version of yourself in post-traumatic growth. We would call this concretization in psychodrama, that we're making physical something that's not physical. For myself, I might choose this little Buddha statue to represent post-traumatic growth for me. And if you chose to concretize post-traumatic growth using an object, you might keep that object next to your laptop, next to your computer, on your desk, as a reminder, a physical presence to remember the message that you just tapped into, or to remember that post-traumatic growth is possible. Now, of course, this is a really small and short example of a psychodrama vignette that was only 30 seconds long and with one role. When we do a full psychodrama, it could be an hour or 2 or 3 hours long with a dozen different roles. In my inpatient work, I might have 10 or 15 clients in the group. This is pre-coronavirus, of course. And I would have 10 or 15 roles within the psychodrama. And we might go for an entire hour in the role play. Somebody might play the role of the client's courage. Somebody else might play the role of the client's resilience. Somebody might play the role of the client's post-traumatic growth. When I'm working with trauma psychodramatically, I'm always starting with safety and strength-based roles, especially in inpatient, where clients are a little more compromised and maybe just getting stable psychiatrically and in terms of their substance use. Sometimes I'll do a psychodrama with 10 strength-based roles, no antagonist role, no trauma-based role, all strengths. And that might be what the client in the group needs. And working with the strength-based roles can be incredibly powerful and corrective. There's a whole lot more I could say about psychodrama, which is probably a whole nother training. It's important that you not try to do a psychodrama until you get some further training in it. It can be a really powerful tool. And because of that, if you're using it without training, you can really cause harm. And psychodrama, unfortunately, has gotten a bad reputation because of its potential to re-traumatize clients. I think it was really co-opted by the therapeutic communities and the encounter movement, where folks were using psychodrama techniques without proper training, and sometimes even in ways that were really confrontational and just not trauma-informed in any sense of the way that we do trauma-informed work now. There's specific trauma-focused psychodrama models that have emerged in the past few decades, and classical psychodrama has become much more attentive to the way that trauma impacts people and integrating trauma theory into our approach. So I'm happy to, if you want to reach out to me to provide resources for where you can learn more about this and pursue more training on it. I know we're coming to the end here, and there's a whole lot more I could say about all these different topics. If you want to reach out to me for resources or questions, I'm really happy to answer those and to communicate with you. Here's my email, scott@phoenixtraumacenter.com. I invite you to follow our Facebook page, LinkedIn page, Instagram page. If you'd like to join my mailing list and be updated about upcoming psychodrama trainings or trauma trainings, you can join our mailing list at phoenixtraumacenter.com/trainings. And here's some upcoming events that I have. Next Wednesday, I'm not actually presenting on this one, but some of my staff are presenting on Gestalt therapy, psychodrama, and addiction and trauma with adolescents. The first International Teledrama Conference is this weekend, where you could get 30 hours of psychodrama training specifically on using psychodrama on teletherapy. And the website for that is teledramaconference.org. I have a presentation on the 22nd for an International Trauma-Informed Art Therapy program, which will include some translation. My topic for that workshop is post-traumatic growth, sociometry, and psychodrama. And then I'm also doing a fundraiser for the American Society of Group Psychotherapy and Psychodrama, looking at the intersection of psychodrama and Maslow's work, self-actualization using Morena's philosophy. So I invite you to stay connected and to join me for some upcoming trainings as well. So
thank you. Thank you, Scott. Well, I want to again thank Dr. Giacomucci. We've come to the end of our time. So as a reminder, we are offering continuing education credit for social workers. A survey will be posted for you to take immediately following this presentation in order to obtain credits. Again, you must have been on for the duration of the presentation to get the credit. You will receive a certificate of completion in the next couple of weeks. We will also be emailing a copy of the slides as well as a link to the recording of the presentation to all attendees. Fortunately, Scott was able to answer many of your questions during the presentation. Our follow-up email will also include information on connecting with Dr. Giacomucci, as well as information to register for his upcoming trainings. If you are interested in learning more, I highly recommend that you explore the resources available at the Phoenix Center. Join us, please, next Tuesday, August 11th, for our next presentation on Back to School, Back to College, Helping Students Succeed Amidst the COVID-19 Pandemic, featuring Jonathan Salzberg, Executive Director of Collegiate Recovery Services at Caron. Watch your email for details on how to register. Please reach out to your local regional resource director at any time for additional information, resources in your area, or questions regarding admission to any of Caron's programs. Our residential campuses in both Pennsylvania and Florida are open and ready to provide world-class care for those suffering with substance use disorder and mental health issues. We have had zero community spread of COVID-19 at any of our sites. Additionally, many services at our regional recovery centers have gone remote but continue to provide outpatient, intensive outpatient, and evaluations via telehealth. Also, our groundbreaking 5-day retreat-style workshop, Breakthrough at Caron, is now accepting new participants with protocols in place to limit the risk of COVID-19. Please visit caron.org or contact your local regional resource director for the latest on our response and preparedness to ensure patients remain safe and healthy while receiving the utmost quality care. Thank you again for joining us, and have a great afternoon. Bye.
thank you. Thanks for being with us today.